Hi, my name is Jina Su, and I'll be presenting highlights from our paper, Parallel Journeys of Patients with Cancer and Depression. Cancer is one of the leading causes of death and disability worldwide, and improving quality of life has become an essential component of cancer care. Depression is one of the most common challenges for patients with cancer, but it is severely undertreated due to limited access to services. Mental health care in cancer context is complex because of neuropsychiatric effects of cancers and their treatments on depression. Therefore, direct integration of psychosocial care services in cancer settings is recommended. One integration strategy that's proven to be effective is collaborative care, which is a team-based approach that centers around the patient with a triad of providers, care managers, and consulting psychiatrists working together to improve the patient's psychosocial health outcomes. Therefore, our research goal is to examine the contextual factors and challenges in depression care through the experiences of these multiple stakeholders and to identify technology design opportunities in supporting collaborative care in cancer contexts. To do this, we partnered with 3 cancer centers where we conducted interviews with 4 different types of stakeholders and contextual inquiries to observe workflows and care practices. We then analyzed the combined data to identify challenges in depression care. Our analysis identified many different challenges at different points of care, which we tried mapping to the timeline of how patients navigate their care. On one hand, we observed that patients experience phases of a cancer care journey, from diagnosis, information seeking, treatment, to no evidence of disease. However, this cancer-centric view inadequately described the experiences of patients whose psychosocial needs do not necessarily align with cancer care. On the other hand, we observed that patients also experience phases of a psychosocial care journey, from identification of depression, psychosocial assessment, treatment, to maintenance. As with the cancer care journey, the psychosocial-centric view alone was insufficient. And that's because these 2 journeys happen simultaneously and involve variable treatment modalities and interactions between treatments. A common misconception is that depression happens due to cancer diagnosis, but really depression can happen at any time. To understand how cancer and depression care journeys interact with each other, we examined the cancer care journey alongside the psychosocial care journey as a design framework, which we refer to as a parallel journeys framework, which can be used to organize observed challenges at each intersection and to identify challenges that may not be directly observed in data. Let's examine a few of these challenges through the parallel journeys lens. I will also illustrate how we can lead a hypothetical patient through an idealized parallel journey with the help of technology. In the identification phase, patients who were just diagnosed with cancer or seeking treatment options often had their depression to appear strong. During treatment and recovery, patients normalized their depression. In general, we saw that patients who hesitated to reach out often found themselves in emotional crises, and the behavioral health providers must drop everything to attend to them. Ideally, patients' stress and depression levels are regularly tracked through self-assessment, with a tool that can monitor and identify patients with depression before it becomes a crisis. Because we have tools for and around self-assessment and monitoring, instead of attending to crises, behavioral health providers can establish a working relationship and a workable treatment plan, guiding patients with psychoeducation ideally before they go into intense cancer treatments. Now, depression treatment phase was the most problematic. When patients moved from cancer diagnosis to treatment to recovery from cancer, depression treatment had to be adjusted. For example, patients may have had a regular cadence for depression treatment during information phase, but once cancer treatment starts, side effects and stressors interfered with depression care, causing it to be deprioritized. In addition, session outputs were not documented, such that patients were responsible for managing their own depression care plan. Ideally, patients receive flexible, timely, and accessible depression treatment through digital psychosocial interventions, tools that manage shared care plans, and communication between sessions to keep them engaged with care. During the recovery, patients often discontinued depression care. Even if they were able to manage their depression, patients often relapsed due to the stress of having to find a new normal for themselves. Because they were discharged from the cancer center where they were receiving depression care, again, they are left with the burden of managing their own care. So ideally, patients are transitioned to more accessible resources such that they can move into the maintenance phase for long-term management and self-efficacy. In summary, we highlighted that thinking of cancer and depression care journeys separately was inadequate and introduced parallel journeys framework through which we organize our findings, identify technology design opportunities, and characterize the whole patient. Finally, this work would not have been possible without my amazing co-authors and our support. Thank you.